So good afternoon, everyone. We are going to get started with today's Brown Bag webinar. Good morning to some of you. This is Leslie Lieberman, and I am the Senior Director of Special Initiatives at the Health Federation of Philadelphia, where I oversee the Mobilizing Action for Resilient Communities, or MARC initiative. Usually I am joined on these webinars by my very technically skilled colleague and MARC Program Director, Claire Reedy, but today she is on a well-deserved vacation, and so I am flying solo and hoping I won't have any technical glitches, but please do bear with me if I do. I'm delighted to have you all with us today for the MARC Brown Bag webinar series. So before we get started, a couple of notes. This session is being recorded and it will be archived on the MARC webinar site. At the moment, all participants are muted, so please use the questions pane on your GoToWebinar control panel to share your comments or questions, which we will address at the end of the webinar. Mobilizing Action for Resilient Communities is a learning collaborative of 14 cross-sector networks that are using the science of adverse childhood experiences, or ACEs, to build the movement for a just, healthy, and resilient world. MARC is coordinated by the Health Federation of Philadelphia with support from the Robert Wood Johnson Foundation and the California Endowment. You can read more about the communities participating in MARC on our website, where we also post our monthly shared learning series, where you can read about key themes emerging across sites and get related resources. MARC has an impressive National Advisory Committee, and I'm sure many of you recognize some of the names and faces here. We're really thankful that they've graciously agreed to take on this webinar series. You can visit the MARC Brown Bag webpage to see the webinar lineup, access the archives, and register for upcoming sessions, including our August 22nd session with our advisor, Mark Dessauer from Spitfire Strategies, on mindful messaging, communications for the ACE and resilience movement. Today, we have the pleasure of hearing from Dr. Angelo Giardino and Nancy Correa. Dr. Giardino is a professor of pediatrics and section head of the Academic General Pediatrics at Baylor College of Medicine. He received his medical degree and doctorate in education from the University of Pennsylvania and completed his residency and fellowship training at the Children's Hospital of Philadelphia. He currently serves as Senior Vice President and Chief Quality Officer at Texas Children's Hospital. Dr. Giardino holds subspecialty certifications in pediatrics and child abuse pediatrics. He serves on a number of boards, including the U.S. Center for Safe Sport, Prevent Child Abuse America, and Catholic Assistance University. He is also the recipient of the Fulbright and Jaworski LLP Faculty Excellence Award. His academic accomplishments include publishing several textbooks on child abuse and neglect, and presenting on a variety of pediatric topics at national and regional conferences. Nancy Correa is the Senior Community Outreach Coordinator for the section of Public Health Pediatrics at Texas Children's Hospital. In this role, she leads community collaboratives to address gaps in practice and knowledge to mitigate childhood adversities and foster resilience in individuals, families, and communities. Nancy's experience includes developing and implementing a strategy to make evidence-based parent support programs more widely available through schools, churches, after-school programs, and healthcare clinics in Houston, Texas. Nancy also is the founding executive director of Can Do Houston, a local nonprofit that prevents childhood obesity. Thank you so much for joining us today, and I'm now going to turn the webinar over to you.
Okay, thank you, Leslie. We really appreciate you being courageous and being willing to run the AV stuff for us. We're going to get started, okay? First of all, I just wanted to say on behalf of Nancy and I, we are just thrilled to have the opportunity to share a little bit of the work that we're doing here in Houston. And as you can see from the title slide, we really want to talk about those practical aspects of how folks in the public health world work with folks in the kind of medical healthcare world, specifically at a hospital system. So I can have the next slide. We're going to give you just a little bit of an overview, and then we're going to use two case studies that I think many of you will have some familiarity with in terms of postpartum depression and abusive head trauma. And we're going to use those as a framework to discuss how our efforts have come together, how we've facilitated some community partnerships, and then how do we get the public health folks to work with the clinicians. So, obviously we categorize ourselves, and, we all have to talk about things that we're really, that's kind of in our wheelhouse. So on the left-hand side, you have the circle, and I love Venn diagrams. So I appreciate Nancy's willingness to indulge me in having Venn diagrams. But on the one side, you have medicine, where you have the clinicians, and they're obviously very focused on individual patients, specific encounters, what happens between the patient and the healthcare provider in that room, and of course, the families involved in that. But the goal of the healthcare provider is really to diagnose disease, provide care, partner with the patients and families, and render treatment. So it's very kind of individual encounter-based. And then when you jump over to the public health side, that's more of a team-based approach to a population or a group of patients. And they're obviously interested in looking at those groups of patients and thinking about prevention and health promotion. Now, there's some overlap in those, and I think what we see is that there's more overlap than there are differences. And I think both the healthcare clinician as well as the public health advocate are very interested in a healthier and more resilient community and the individuals in those communities. So we found a lot of common ground, even though our training is a little bit different and some of the vocabulary we use is different. So maybe just a little word about Texas children so that you have a context. So everything in Texas is big, and I'm relatively new to Texas, so I got here 12 years ago. So, but for many, many years I lived on the East Coast, and actually lived in Philadelphia and New Leslie there. So in Houston, our system is an integrated delivery system. We have 3 hospitals. We serve 3.5 million patient encounters per year, and that's in our integrated delivery system. So the hospital, the specialists at the hospital, the labs, the diagnostic services at the hospital, as well as our pediatric association, which is composed of 53 pediatric practices, which have 260 pediatricians. So it's a very large pediatric primary care network. Actually, it's the largest. So again, in Texas, everything's big, so we love that moniker that we're the largest. And then in addition to the hospital and our practices, we have a health plan, which is an HMO that covers 400,000 enrollees in the Harris County area. And Harris County is where Houston is. And that 400,000 members, that's half of the Medicaid marketplace. So there's another 400,000 kids that are in other health plans, but our plan is the largest, and we cover that 400,000. And then we have a pavilion for women in our system, which is essentially an OB/GYN practice and hospital, and we do 6,000 births. So we come in contact with a lot of families, and we are very, very rooted in child advocacy and maternal health. So you might ask that, okay, so we're this big center, we're actually the largest children's hospital in the United States, we're ranked number 4 in the U.S. News and World Report. Why would we be interested in some of these resilience issues? And I think the roots of that come from many different avenues, but it's pretty clear that if you're rendering a lot of high-tech care, you have a sense that you're serving people and maybe returning them back to maybe not the greatest circumstances. And certainly that's what our clinicians tell us. We're a really large global health provider. We have several clinics in Africa where we serve patients and families with HIV/AIDS. We're expanding that to hematologic disorders like sickle cell, and we're also expanding now with a fairly large grant to oncology care in Africa. So we have a lot of folks who are interested in global health, and as we were interacting with them, we realized that actually Houston and Harris County are on the globe, and people like Nancy and I, we say we do global health, but we do the domestic side of that. So we really had a sense that we needed to embrace the people in our community, and particularly the people that are somewhat disadvantaged in our community. So hence the idea of a section of public health pediatrics. And our mission statement is to create a healthier future for Texas children and families by leading in patient care, education, research. That's our general mission statement for the hospital, that seeks to mitigate childhood adversities and to accentuate individual, family, and community resilience. So we got a lot of buy-in from the hospital administration, from the medical school, and certainly all of our community providers that this made a lot of sense, that we should be embracing this mission. And we have a set of clinical services in that section, which are the typical ones you would expect. The child abuse programs in there. We run a children's assessment center, which does multidisciplinary care for children suspected of having been sexually abused. We're launching a foster care clinic. And then we have this focus on public health. And front and center in the section of public health really is the social determinants of health. So we have a center for the study of adversity, resilience, and education, which Nancy is really a central figure in. And then we have a number of community work groups. Then we call them the ACE work groups. So with that, I'm going to toss it over to Nancy, and she can tell you some of our experiences with working both at the hospital and in the community on the ACEs stuff.
Well, thank you, Dr. Gino, and thank you, Leslie, for the opportunity to kind of share some of our work around our adverse childhood experience work groups. Our work groups, are dedicated to figuring out how can we move the needle to mitigate childhood adversities in our community. We've kind of convened local government, community nonprofits, healthcare, and academia to kind of systematically address the adverse childhood experiences. Our section has been around, just over a year now, and we kind of identified 4 adverse childhood experiences as our starting point: intimate partner violence, postpartum depression, food insecurity, and abusive head trauma. And today, in the next 20 minutes or so, I'm going to kind of give a case study of 2 out of the 4 that we're working on around postpartum depression and abusive head trauma. So this very busy slide kind of shows the framework that our adverse childhood experience work groups use when we are addressing a childhood adversity. It's really important to us to be systematic and make sure that the work we're doing and the strategies that we're implementing are evidence-based and have the most likelihood of being successful. As you can see from the diagram, that assessment phase is really important to us when kind of identifying our strategy. And just, a recent example for that, we are working on trying to improve intimate partner violence screening in Houston and Harris County, and we just wrapped up a series of 3 focus groups with survivors. And what we found from listening to the survivors is that most of them have been screened by a healthcare professional, but none of them were by themselves when they were screened. So that's a really, really important lesson. We know best practices that women are screened alone for intimate partner violence, but now we know that that's not happening in our community, and our strategy on how to improve screening is going to look very different, knowing that that key piece of information is missing in our current practice. So we use the findings from our assessment to then do direct service programs that support children and families. It could be research and quality improvement projects, advocacy, or education and training, again, just based on what we find in that assessment phase. So first, we're going to look at postpartum depression. And, what we challenged ourselves with was how do we improve the early identification, referral, and treatment for women with postpartum depression. And as with all of these childhood adversities, it's not going to be a one-pronged approach. So here at Texas Children's, along with our community partners, have been kind of working on 3 strategies to improve these services around postpartum depression. So first, training pediatricians to screen and refer mothers with postpartum depression to treatment, assessing the available treatment options, and then based on the results of the assessment and our screening initiative, we're piloting a model to increase treatment and care options. So for our screening initiative, we through a grant, Medicaid waiver grant, we are training all 53 of our pediatric practices to screen for postpartum depression. We've currently trained 36 pediatric practices and 3 obstetric practices. we provide a 1-hour training for the pediatrician and clinic staff on signs and symptoms of perinatal mood and anxiety disorders, how to administer and score the EPDS, the Edinburgh Postnatal Depression Scale, how to integrate the screening workflow into their practice, and then how to document the screen and submit an electronic referral via our electronic medical record. Here's a little bit this diagram shows the workflow of how we're integrating postpartum depression screening into the practices. And what's really an advantage we have here in our workflow is that we have this shared electronic medical record between our pediatric practices and the women's place, where women can go to receive counseling and psychiatry for that postpartum depression. So the pediatrician can enter it into the electronic medical record, the referral goes to our women's place, and then the women's place will call the mom to schedule that appointment to see her to provide an assessment and treatment. To date, our obstetric and pediatric practices have screened, completed over 21,000 screens to mothers in our community. For our protocol, we have identified a score of 10 or higher on the EPDS as a positive, and we've had over 1,800 positive screens with an average EPDS score of 4. Of those 1,800 screens, just under 1,700 of the women consented to receiving a referral. In our obstetric practices, 80% of the women that were referred completed an appointment with a mental health provider within 60 days. Our rate of completed appointments with pediatric practices is at 28%, so clearly an area for improvement. When talking with the project manager on, why is that number so low and what can we do to increase it? A lot of our pediatric practices are geographically very, very spread out. So some of these women, they're getting screened, an hour away from where we're able to offer services. So we think the locations is a big driver of it, as well as we recently trained a lot of new pediatric practices on the screening. And typically what we'll see is the treatment rate being pretty low for the first few months as the practices are learning how to do the screening, how to integrate it, and then it increasing over a few months' time as the kinks are worked out of the system. So that project has been going on for the last few years, and then just this past January, our health plan at Texas Children began reimbursing pediatricians for screening for postpartum depression. And then our work group is, as I mentioned before, very involved in policy and advocacy, and with many of our community partners, we're able to get a bill passed this past May at the Texas legislature that now requires Medicaid to reimburse pediatricians for postpartum depression screening. Prior to May, Medicaid would reimburse OBs and family practice doctors, but they would not reimburse pediatricians since the mom is not the patient. But we are able to demonstrate and get agreement that the pediatrician is a better point of care, and that postpartum depression impacts the health of the child enough that we should be having pediatrician screening and they should be reimbursed for it.
So Nancy, I would say that's like the example of like a Texas miracle. So, Texas is a pretty red state, and to get legislators that meet every other year to agree to pay for something extra was a miracle, and we're very excited about that.
Yes, I'm very grateful to all of our work group members and community partners that helped push that legislation through. So now we've run into the challenge. As our screening rates increase, we anticipate a demand for services to increase. So as Dr. Giardino explained, Harris County and Houston are very big. So we estimate we have about 12,000 to 15,000 women with postpartum depression in our county each year. So we conducted an assessment to see, what services are available to meet the needs of these 12,000 to 15,000 women. So my team and I, we called every single provider we could find in our county that offer services for postpartum depression. At first glance, it doesn't look too bad. There are 24 agencies with 56 locations in Harris County that provide postpartum depression services to meet the needs of the 12,000 to 15,000 women. However, once we dive a little bit deeper, the story looks very different. So this map shows the 56 locations that offer the postpartum depression services. But now if we only look at those locations that accept Medicaid, we're down to 42 locations. And this is really important because over half of births in Texas are covered by Medicaid. And then, as many of you may know, so Medicaid coverage after the birth of a baby, a mother will be kicked out off of Medicaid 60 days after the birth of their child. And in Texas, they get moved over to a women's health program called Healthy Texas Women that provides very light coverage for postpartum depression. So if we've now reached after 60 days and we need a provider that accepts Healthy Texas Women, we've now gone from 56 locations to 42 locations to 26 locations to serve the needs of our moms. Now let's say you are a pediatrician and you would like to get this mother into care within 2 weeks. You don't want them waiting more than 2 weeks to see a provider. Now we're down to 19 locations. And then if you need a language other than English or Spanish, we're at 17 locations to serve the needs of 12 to 15,000 women with postpartum depression each year. So clearly, this is not okay. These 17 locations are not going to be able to serve the needs of all the women with postpartum depression in our county. So now, in partnership with our Pavilion for Women, we are piloting a study to see if home visitation programs and support groups are as effective as a referral to a psychiatrist for mothers with mild to moderate signs of postpartum depression. This is a randomized control trial where moms that consent to participate and that have between a 10 and 20 on the EPDS will be randomized to either standard of care, home visitation, or support groups. And our hope is that the findings from this study will enable us to implement a tiered model of care for postpartum depression. So we're able to kind of reserve the psychiatrist for the women with the highest needs around postpartum depression, and then have home visitation and support groups for moms with milder versions of postpartum depression. And then we are also partnering with our state leaders on the implementation of House Bill 2466. And I can say everything that we've done in postpartum depression could not have been done without the partnership between our hospital system and our community public health partners. It really was the interface of both of these that have enabled us to push legislation through, to pilot new screening initiatives, and then to conduct an assessment to understand and to be able to really demonstrate that we don't have enough services and develop a model to try to address those limitations. So for our second case study, we are going to move on to abusive head trauma and parent support. We challenged ourselves with how do we decrease rates of abusive head trauma and provide more support to parents of young babies. We really kind of did a two-pronged strategy to address this question. One, around trying to make evidence-based parent education more available to parents through hospitals and community organizations, and really try to normalize participation in parenting programs. In Harris County and Houston, kind of the general feel is that going to a parenting class is for those parents, and we're really trying to get away for that, is that, participating in a parenting program and parent education is just a normal standard part of being a parent that all parents want to and should do. So we went about this, again, through a few different ways, one really driven by our the hospitals, and then one driven in our community. So the two surgeon-in-chiefs at our two children's hospitals, so Texas Children's Hospital and Children's Memorial Hermann, both located in Houston, Texas. So the two surgeon-in-chiefs came together to form a coalition to look at this together and, identified the period of purple crying. It's an evidence-based parent education program that is delivered at hospitals when by labor and delivery nurses before moms are discharged. And it kind of teaches parents about normalizing infant crying, teaches parents how to soothe their infants, with the ultimate goal of preventing abusive head trauma, which is also more commonly known as shaken baby syndrome. So through the work of my incredible colleague, Carrie Kane, as well as this coalition, they had 10 local hospitals signed on to begin delivering period of purple crying at their hospitals to 20,000 families this year. This month will be our last month in our first pilot year where we are trying to reach these 20,000 families through our 10 local hospitals. So this fall, we will be following up with evaluation and kind of looking at the trends in abusive head trauma to see whether or not this initiative made a difference here in our community. So in addition to the work going on at the hospitals, our community partners at Children at Risk worked to train 86 providers from 19 different agencies to deliver an evidence-based parent program called Triple P, or Positive Parenting Program, at churches, schools, after-school programs, daycares, clinics, and social service agencies. Similar to our initiative at the hospital, where we are trying to offer a parent education program where parents, a place they already go, a place they're already comfortable. Similarly, offering it through their churches, their schools, and not just through social service agencies, to really try to normalize that participation in parenting programs. And then also developed a website, smartparents.org, to improve access to parenting programs so parents could know where to go to access these parenting programs, and to kind of decrease the stigma and kind of promote the availability of these classes. And then two more initiatives we have going on at Texas Children's around parent support. One is Safe Babies, a 4-arm research trial that we're conducting looking at maternal supports and the impact on maternal stress and bonding. We are implementing this at 4 of our pediatric practices, looking at how, again, the healthcare system and the pediatricians can help with that parent bonding and preventing abusive head trauma, as well as Upwards, which is a really neat program that teaches parents how to engage with their young children and tries to kind of reduce the 30 million word gap and have parents talking more to their kids. And you can see on this picture, the little device that they're holding is like a Fitbit for language. So the kids wear these little Fitbit type devices, and it measures how many words are spoken to them in a day, how many conversation turns there are, and then the number of hours of background noise from TV and media. And then these parents get together each week to and kind of go over their curriculum, and they go over their reports from their Fitbit-like devices to improve their engagement with their children. So from these efforts around, preventing abusive head trauma, and then trying to improve screening, detection, and connection with treatment for postpartum depression, the interface of public health and hospital has been critical in both of these efforts. A few of our lessons that we've learned along the way is, collaboration between these two entities are key. Being very outcome-oriented and being very clear what outcomes we're working towards was really important in getting our community partners and the healthcare setting kind of signed on. I would also recommend, for those that are representing community organizations or public health that want to partner with the healthcare system, is finding a champion with the healthcare system. I am still fairly new to working in a hospital, and healthcare can be tricky, it can be challenging, and there are a lot of strengths, but there are also limitations. So kind of having that champion within the healthcare system that can help you navigate, I think, is really important in kind of mitigating adversities in our communities. And then again, just kind of capitalizing on the strengths of all the partners as key to developing these strategies at the interface of public health and hospitals.
So, I think at this point, I think Nancy's done a really great job at highlighting a few of these case studies, and I think you can see how beneficial it is to have the public health expertise connected to the healthcare expertise. And it certainly has, like when you look at those maps, that's like in the wheelhouse of public health, but a clinician says, oh, that's genius, you mapped everything. So it really, I think, had a kind of a pretty striking effect, and it really kind of helped us. So Leslie, I think at this point we'd be interested in throwing it open. We're not saying we've figured it out, and we know many of the people on this webinar are, kind of doing equally exciting work. So we're really open to kind of now having a dialogue and seeing what people's response to what we presented, and if there's anything that we can kind of comment on as well.
Great. Thank you so much, Nancy and Dr. Giardino. And because we're actually a nice-sized group today, I think we can take questions by phone. People are also welcome to type in their questions. But if you would like to ask your question over the phone. If you raise your hand, then I can unmute you, and you can go ahead and speak directly to Nancy and Dr. Giardino. So, or as I said, feel free to type your question or comment into the question box. And I'll go ahead and kick us off with one question that I was interested in, and that was, can you talk a little bit more about the process that you use to get the buy-in around including adversity with your section? And as a second part to that, did that include training staff about ACEs, and do you also integrate any language and training, professional development around the concept of trauma-informed care? And I'm going to mute myself.
Okay, I think I could start, and then Nancy can follow up. So, you know, I think certainly in pediatrics, more and more individuals are learning about social determinants of health and ACEs. So there was this kind of movement, if you will, within the field of kind of saying there's something out there that we should be getting our hands around. And then the folks that probably speak most eloquently about ACEs in our system were the child abuse folks, and it really helped to have the surgeon-in-chief. And, you know, in medicine, you know, there's obviously a pecking order, and a trauma surgeon is kind of, you know, top of the heap. Neurosurgeons and trauma surgeons are kind of, you know, maybe a transplant surgeon, they're big. So when they kind of get frustrated that we're not doing enough with child abuse, it really kind of had a catalyzing effect. And they were able to call, you know, a group together and say, you know, what are you doing? And of course, then the child abuse folks said, well, we've really got to start thinking about adverse childhood experiences. So that laid the groundwork for this sense of urgency and like you need to do something. And then the medical leadership worked in collaboration with the hospital to say, well, you know, the way we solve things is that we have focus. We have a group of people who make this what they pay attention to, and they do the needs assessments, they do the planning, they do the academic work. So hence was born this idea of having a section that would take on a bona fide clinical activity, which is the child abuse team, but then also would take responsibility for the community work. And one of the first things that we said as a leadership team when we were forming the section is this section has to have public health folks in it, because you need people who know how to do public health if you're going to address public health. So through a lot of collaborations, we knew about Nancy, and we were able to attract her to join our team. So the clinicians who were interested in ACEs, and then people like Nancy and some of her other colleagues at School of Public Health, really started collaborating. And then this idea of having work groups and catalyzing the community to work in partnership with us and us with them really took hold. So, you know, we're fairly new at this, but at each step of the way, people see the tremendous value of having public health professionals sitting at the table. And I think the community groups and the public health folks see the value of having the clinicians, because there's a certain value to having, you know, people who actually treat the patients at the table as well. Nancy, would you add anything else to that?
I think that's great, yeah. And in terms of your second question, so at Texas Children's, we are not universally screening our patients for adverse childhood experiences or social determinants of health. It is an active conversation, but where we currently are is we have several pilot studies, both with our inpatient populations and outpatient populations, where we're looking at screening for social determinants of health and adverse childhood experiences. So we're screening them, providing them with resources, and then following up 6 months later to see were they able to access the resources. This is through our colleagues, Dr. Claire Bikini and Dr. Michelle Lopez. And we think that it's really important because, again, at the beginning, we explained we have 3.5 million patient encounters each year. So as we kind of begin thinking about screening, which is a very active conversation, we want to make sure that we are able to connect these families with resources, and that it's going to make a difference and help improve outcomes for those families. So as we're starting to screen for postpartum depression. We're actively looking at, strategies to improve screening around intimate partner violence and food insecurity, and then continuing with these pilots, again, to make sure that we have a appropriate positive response that will improve outcomes for patients before we start universally screening across the board.
Thanks. We do have a few questions coming in from participants. Here's a question. Is there a place online where we can learn more about the Safe Babies curriculum, and does it include attention to intimate partner violence?
The Safe Babies, so this is our 4-arm research study. It is not available online because it's still in the kind of development phase right now and the really testing to see whether or not it works. Intimate partner violence is not currently a component of the Safe Babies program.
Okay, thank you.
If people want to learn a little bit more about that, if they email Nancy or I, we can certainly get them some of the information if that would be of interest to you.
Yes, more than happy to connect you with our kind of research coordinators and the PI if that's someone's interested.
Because, you know, we consider the MARC people our family.
Yes. So
we would be happy to share with you guys.
Well, and that actually addresses, I think, another question here, which is how can we follow progress on your work? And I'm assuming that would be also being able to be in contact with you. And is there any other way that people can follow up on what you're doing?
Well, Leslie, I hope you invite Nancy and I to give another webinar in a few months, and we could do the other 2 case studies, and then we could give you an update of how the data is rolling in.
We'd be absolutely delighted to have you do that. So that's easy. And we'll make sure that your emails are available to folks. So another question is, in working on the policy work that you did you have data to present to payers and policymakers that was part of your ability to persuade them to do postpartum, to reimburse for and do postpartum screening?
Yes, so in partnership with our kind of Representative Sarah Davis office, the government relations here at Texas Children's, as well as our community partners, Mental Health America of Greater Houston, we provide, and then our health plan as well, provided them with a lot of data to understand, you know, kind of the costs and benefits.
Okay, so here's another question from a participant. Can postpartum depression support services be available for parents who have children with disabilities? Often they feel guilt or blame themselves for their child's conditions.
So I'll start off and then Nancy can follow up. So, you know, these are kind of concentric circles. So it's been really hard to find, I think, mental health service providers to begin with. And then I think Nancy's mapping really shows that. And we have identified through some other initiatives that mental health professionals or behavioral health professionals specifically trained in how to work with families with special needs are even fewer than for the routinely developing population. So there are a few, and we haven't found a lot of them. And again, it's somewhat surprising on one hand, because there are a fair number of children that have special needs. You know, depending on which study you look at, 14 to 18% of children have a special need. But the mental health providers don't always specifically specialize in that and understand those family dynamics. So when we find somebody, we latch on to them. So we have had some success at finding a few. And just to build on that, we have a program at the hospital specifically for people with medical complexity or special needs. And because we couldn't find a lot of resources in the community, we actually did hire a psychiatrist whose specialty is working with families with special needs. And we're using him to help build capacity because in addition to his direct service work, he's also doing some training of the behavioral health folks that we tend to work with to help build that capacity. But that is a real concern and a real challenge, and haven't really figured out how to get more folks to understand the dynamics with patients with special needs. But Nancy, did you have anything else?
Sure, and I would add, you know, kind of your question is really in the spirit of why we are doing the current trial in postpartum depression with the home visitations, the support groups, and the kind of standard of care psychiatry, because we know that we want to make sure that our specialists that do have that, you know, special knowledge and that our psychiatrists that they have the availability. So if we do have a EPDS score at one of our pediatric practices that scores a 25, which is a very high score on this training, that they can get into the psychiatrist the next day, that they can get that care they need immediately, because and the psychiatrist is not, their schedule isn't completely booked with cases that could be receiving a lower level of intervention and be just as effective. So kind of the spirit of your question, we absolutely agree with, and that's kind of why we're starting the study, to make sure that people are getting appropriate levels of care.
Thank you for those answers. We still have a minute or two left. If there are any other questions that you'd like to pose in the questions chat box or by raising your hand. And just waiting to see if those come in, I'll ask Nancy and Dr. Giardino if we can, when we post, if we can post your slides on our website and include in those contact information, we'll just revise those slightly so that people can have that. Would that work?
Oh, yeah, that would be fine. And we look forward to hearing from any of the MARC participants.
Great. Well, it looks like there are no more questions at that time, so I am going to take back control of the slides and basically thank everyone for coming today and participating in our webinar, and hope that you have a great rest of your day. Thank you so much, Dr. Giardino and Nancy, for that wonderful presentation. Goodbye, everybody.
Thanks.
Bye, thank you.
Bye-bye.